Welcome back to Health Economics. Today we're going to start on Chapter 2. We're going to get halfway through it and then we'll finish it up next class. And the title of the chapter is The Demand for Healthcare. To motivate this chapter a little bit, I'm going to remind you of one thing that I talked about last class, and that is that the reason we have a separate class for health economics is because a lot of the models and tools that we use in general microeconomics classes completely fall apart when we try to apply them to healthcare markets. And so what we're going to do today is we're going to go back to the demand curve, the traditional demand curve that's used in a regular microeconomics class, and ask ourselves, is this demand curve correctly drawn when we're thinking about a market for a healthcare good? So on the screen, I have a reminder of what a demand curve looks like. Typically, we draw a demand curve with a negative slope. And so what this tells us is that if you have a particular product and you price it at a high level, not very many people want to buy it. As you lower the price, more and more people buy it. And so what this tells us about the characteristics of people in the world is that for most goods, they're sensitive to the price. How many units they demand is dependent on what you price that good at. On the screen now, you're going to see a non-traditional demand curve. This is just a vertical line. First of all, think about what a vertical demand curve would even mean about the world. So if you have a vertical demand, what you will see is that if you have a price of 0, people demand a given number of units, perhaps 10. If you take the price and you raise it up from 0 to $1 million, people still demand 10 units. And so in this case, people are insensitive to the price because it doesn't matter how much you increase or decrease the price level, people still want exactly the same amount as before. The reason I'm putting this demand curve up is because it's at least plausible that in healthcare markets, we might have a demand curve that's vertical, which would be very non-standard. And the reason it's plausible is because you can think about scenarios such as chemotherapy, where individuals truly don't care what the price is. They're going to want a particular quantity. So the story would go something like this. A patient goes into the doctor. They're diagnosed with cancer. The physician says, in order to live, you need 5 rounds of chemo. Well, if the price of chemo is $1 per round, the patient wants 5 rounds. They don't want any more of that just because it's cheap. Similarly, if the price of chemo is $10,000 per round, the patient wants 5 rounds. They don't want like 3 rounds because it's kind of expensive. They want a particular quantity, and the quantity that they want is unaffected by the price level. Up until a few years ago, or not a few years, a few decades ago, I should say, the economics profession sincerely didn't know what the shape of the demand curve for healthcare was. And like I mentioned, it's very plausible that the demand curve could be vertical, but it was very difficult for economists to figure out what the true demand curve looked like. And the reason it was difficult for economists to figure out what the shape of the demand curve was because if you're trying to trace out a line, you need different coordinates to plot. And so what that means in the case of healthcare is in a particular goods market, we need some people who have to pay a high price for it, and we need some people who have to pay a low price for it. The only place this really shows up in healthcare is when we have some people with insurance and some people without insurance. And so what happens in cases like this is you'll have a market for a particular good, perhaps it's ventilators. People who do not have health insurance have to pay a very high price for ventilators in the event they use one, because they're going to have to pay out of pocket for it. People who have health insurance are going to have to pay a much lower price for a ventilator in the event they have to use one because insurance picks up the tab. And so what is a tempting approach is to try to figure out what the shape of the demand curve is by comparing people who have insurance and have a low price relative to people who do not have insurance and have a high price, and then looking at the differences in the two groups' quantity demanded. The reason this is actually a terrible idea is because if we're going to actually figure out what the true demand curve looks like, then what we need is we need people who are not only exposed to different price levels, but we also need those two groups of people to be exactly identical in every other respect, withstanding the price that they're exposed to. And so what this means importantly is that the two groups need to be equivalent with respect to their underlying health. So as we talked about last class, health is this invisible thing that it's kind of hard to model, and it also influences our demand for medical products. So if I'm a sick person and I have a poor baseline health, I'm more likely to need a ventilator regardless of what the price of a ventilator is. Similarly, if I'm a pretty healthy person, regardless of the price, I'm less likely to need a ventilator. So this creates problems when we're trying to compare insured and uninsured people in order to capture some kind of variation in price point exposures, because the people who have insurance and have a lower price generally have the insurance because they know they're kind of sick, and so they buy the health insurance because they think they're going to need it. And the people who do not have health insurance and have the high price oftentimes don't have the health insurance because they're generally healthy and they don't expect that they'll need it. And so when we observe differences in the quantity that people with a high and low price demand, we can't necessarily say that that difference is because they have different price levels. It could just be because they have baseline disparities in their level of health, which are driving the disparities in the quantity demanded. What we would like to do theoretically to uncover what the demand curve looks like is we would like to have groups of people who have different prices they're exposed to, but we want those people to be exactly identical to everyone else. And so the ideal experiment, if we could run it, would be to take the universe and to clone it so that we have parallel universes. And then what we would do if we had unlimited power is we would go to the first universe, we would assign it a given price level for medical care. We would go to the second universe, we would assign it a different price level for medical care. So maybe everyone in the first world has to pay $10 for medical care. Everyone in the second world has to pay $5 for medical care. Because these two worlds are clones of each other, they don't differ in any way at all other than the price of medical care that they're assigned. And so what that means is before we assign them different prices, we would expect both of the worlds to consume the same level of medical care because the health of the two worlds is the same at baseline. So what we would do theoretically is we would have this massive stopwatch. We would assign both of the worlds different prices. We would start the stopwatch and say, okay, universes, live your lives. Each universe would be the same again in every respect other than their price point for medical care. At the end of time, we would stop the stopwatch. We would go to the first universe and record how many units of medical care they consumed. We would go to the second world. We would record how many units of medical care they consumed. If there is any difference in the quantity demanded at the end of the experiment in either world, then we have to attribute that back to the difference in the prices that they were assigned at the beginning of time, because at the beginning of time, they were exactly identical to each other than the prices, and so we otherwise would have expected them to kind of move forward on similar trajectories. It's quite obvious that we cannot perform that experiment, and so what researchers do in real life is we try to mimic that, and we try to mimic parallel universes by using randomized control trials. The idea of a randomized control trial is we're kind of trying to construct a parallel universe in miniature. And so the way RCTs, or randomized control trials, work is that a researcher will gather a group of participants for their experiment, and for each experiment participant, they will assign them at random a particular level of treatment. So you might have a sample of 20 people, and you would randomly select half of them and say you get a price of $10 for medical care. And then you would take the other half that are randomly selected and you would give them a price of $5 for medical care. What's critical about randomized control trials is that treatment assignment is random. And what that means is that when you partition the group between the individuals who get the $10 price tag versus the $5 price tag, those groups on average should be similar to each other in terms of their baseline health because the price tag was assigned at random. So what this means is that if we observe these two groups in terms of how many units of medical care they consume, And if we observe that there's a difference in how many units of medical care they consume after they've been assigned different price levels, then that difference, again, has to be attributed back to the different price level assignments, because it clearly couldn't be because one of the groups was sicker than the other group. Because if you're assigning people at random to a group, then chances are both of the groups are going to look pretty similar to each other at the beginning of the experiment. So ideally, this is what we would like to do. We would like to randomize the price of healthcare across people to figure out what the slope of the demand curve for healthcare is. It's actually quite difficult to implement this type of a research design, because in order to get an experiment to be approved by a university, it has to pass approval from an institutional review board that says the experiment is ethical. It's quite hard to make the argument that if you're randomly assigning some people a very high price for medical care, that that's ethical. So up until several decades ago, this experiment was not conducted, simply because it's a really, really hard experiment to conduct. And so meanwhile, the economics community is just left twiddling their thumbs in terms of what the demand for healthcare looks like, because we don't have any clean way to kind of uncover what the slope is. This changed when a group of researchers out in California decided to conduct an experiment very similar to what I explained. And the name of this experiment was the RAND Health Insurance Experiment. And the way it worked was the researchers gathered 2,000 families from across the United States, and they had various recruitment cities, one of which happened to be Charleston, South Carolina. And they took these 2,000 families, and then at random, they assigned the families a co-payment rate. Okay, what is a co-payment rate? A co-payment rate is the fraction of a medical bill that an individual has to pay. So in this experiment, they took the families and they effectively tossed them at random into one of 4 buckets. If you're super lucky, you got tossed into the first bucket where the co-payment rate was 0. That meant that if you went to the doctor, you paid 0% of the medical bill. Some people were randomly tossed into another bucket where their co-payment rate was 25%. Others were tossed into the 50% bucket. Others were tossed into the 95% bucket. Okay, critically, the families were put into buckets randomly. So what that meant was that when the experiment started, you had 4 groups of people who on average looked very similar to each other across the different buckets with respect to their health, but they clearly differed with respect to how much of a medical bill they were liable for paying. So the researchers, they did something similar to this gigantic stopwatch. They took these families, they assigned them different co-payment rates. They took a stopwatch, they said, go, live your lives. We're just gonna watch what you do. So this experiment occurred from 1974 through 1982. At the end of the experiment, effectively the stopwatch stopped. The researchers went to each bucket and they looked at how many units of medical care the people in each bucket consumed. So this gave them a price and a quantity coordinate for each bucket. In the 0% bucket, the price was 0, and they could observe what the quantity was, and they can do a similar thing for each of the buckets. It's useful to step back and put yourselves in the shoes of the research team and consider what you would expect to observe in the final cut of data if what is true about the universe is that the demand for healthcare is downward sloping, and then also what you would expect to observe in the final cut of data if what is true about the world is that the demand is a vertical line. So what you would expect if the demand slopes down is that across the buckets, you would expect there to be differences in the quantity demanded of medical care because there was variation in the price levels. And specifically what you would expect is that for the people who had free medical care, you would expect them to have much more healthcare utilization than the people who had to pay more amounts of money for medical care. On the other hand, if what is true is that the demand for healthcare is vertical, then what you would expect is at the end of the experiment, everyone across the buckets should have similar levels of healthcare consumption. In other words, the quantity demanded of medical care in the 0% bucket should be exactly the same as the quantity demanded of medical care in the 95% bucket. What did the researchers find? On the screen right now, I have a table that shows a brief portion of the results from the study. And in this table, what I've shown you is across rows, there are different copayment rates. And then I show you at the end of the experiment the number of outpatient visits per year that people with that particular copayment rate actually realized. So first of all, what is an outpatient visit? An outpatient visit is any kind of healthcare visit that you have where you are not admitted to the facility. So if you swing by the doctor's office for a checkup, that's an outpatient visit. If you go to the hospital for lab work and then go home that same day, that's outpatient visits. The first thing that the research team uncovered was that across the different payment tiers, there were differences in how many outpatient visits the people realized every year. And in particular, the people who had cheaper medical care had more outpatient visits than the people with expensive medical care. So this suggested that the demand for medical care is downward sloping because as you increase the price, the quantity falls. However, it's a little bit more nuanced. So when you're tracing out demand curves, you have to trace out demand curves for individual markets and look at every market separate from every other market. So another market that the research team looked at was the market for inpatient visits. Inpatient visits are visits typically to hospitals where you're admitted to the hospital. So inpatient basically means that you stay the night there. In the next column of the table, I have the number of inpatient visits per year that occurred on average across the patients in the different buckets. There are two notable things to kind of highlight in your mind. The first thing is that as you move down the table, the price increases and the number of inpatient visits decreases. This tells us that in the case of inpatient care, the demand is also downward sloping. However, what I want you to recognize is that the spread in the numbers from the top of the table to the bottom of the table are much tighter when you look at inpatient care relative to when you look at outpatient care. Visually, think about what that means. If you have a tighter spread in numbers, and the numbers that we're looking at are quantity demanded, that means that the quantity demanded along the x-axis of a demand curve is not moving very much as you're moving the price. So if you have a price change and quantity demanded changes just a little bit, that means the slope of the demand curve is very steep. So in other words, the steepness of the demand curve varies between outpatient care and inpatient care, and it's steeper in the world of inpatient care than it is in the world of outpatient care. So this begs the question, why are people more insensitive to the price of inpatient care than they are to the price of outpatient care? The typical pattern that we see when we look at these markets is that in markets where the good is something that you really need to live and it's kind of a necessary product, in those markets, people are less sensitive to the price. And this is intuitive. For things like Band-Aids, where I definitely don't need that to live, well, if the price of Band-Aids is $15 per box, I'm just going to quit buying Band-Aids. And so in that case, my response has been very extreme, and I'm very sensitive to the price. Therefore, the demand curve is relatively flat. For markets like hospitalizations, where if I need it, I need it, I'm going to care less about the price. And so I'm going to be more price insensitive, and the demand curve is going to be steeper. To drive home this point, I'm going to give you a couple of head-to-head comparisons of different healthcare goods, and the task that we're going to go through during this lecture portion of the class is to identify for the two goods that I give you, which good you would expect to have a steeper demand curve. So a steeper demand curve, again, is just consistent with people being less sensitive to the price. Head-to-head comparison number one is we are going to compare pediatric checkups to adult checkups. And again, what I would like you to think through is in which market would you expect the demand curve to be steeper? In the pediatric checkups world, we're thinking about healthcare visits for little kids, and in the adult checkups world, we're thinking about checkups for adults. The argument would go that we would expect the demand curve to be steeper in the market for pediatric checkups And the reason for this is because typically parents care more about the health of their children than they care about their own health. And so if their kid is sick, they're going to bring them to the doctor regardless of the price. Whereas if they're sick, maybe they'll stay home if the price is super high. And so in this case, pediatric checkups should have a steeper demand curve. Comparison number 2 is dental cleanings versus ER visits. And again, the task is to think about which market you would expect to have a steeper demand curve. In this case, we would expect ER visits to have a steeper demand curve. The reason for this is if you are in need of emergency services, you're not really going to care what the price is. You're going to go because there's an emergency. And so for that reason, your demand curve is going to be really steep. If you have a sore tooth, you're probably going to want to go to the dentist, but if the price of a dental visit is super high, maybe you'll just stick it out and not get the care that you need. And so for dental cleanings, you're pretty sensitive to the price, and so your demand curve is going to be less steep. Final comparison is chemotherapy treatment versus chiropractic care. And again, the question is, which goods demand would we expect to have a steeper slope? Chemotherapy is the treatment you receive for cancer. Chiropractic care is what you get when you've got a sore back. This one's pretty obvious, hopefully. We would expect chemotherapy treatment to have a steeper demand curve because if you have cancer, you're not going to care very much what the price for chemo is. Whereas if you have a sore back, whether or not you go to the chiropractor is probably going to be dependent on what the price tag is. Okay, we're going to break for questions for 10 minutes. After 10 minutes, we're going to resume for the exercise for the day. So feel free to chime in on your questions, and I will see you in 10 minutes. And we are back. So before I give you the exercise for the day, as I was preparing for this lesson, there was a story that I remembered, and it's kind of funny, so I thought I'd tell you a funny story before I make you do work. In the world of health economics and in the world of health policy, the RAND health insurance experiment, it's like this enormous thing that everybody knows of. And the designer of the experiment is a researcher who's still alive. His name is Newhouse. And he's just kind of this revered person in health econ worlds. Well, a few years ago when I was doing my postdoc at UC Davis, I was presenting some research at a conference. And I got up, I started presenting, and there's an older gentleman sitting towards the back of the room, and he raised his hand, and he was kind of questioning something that I was doing, and I kind of thought I was doing it right, so I kind of told him I thought I was doing it right, and it was all cordial, but we definitely just didn't agree on this. So that was that. The conference ended. I went to dinner that night with one of the physicians that I was working with who was in the room when this encounter happened. And he was like, "Lindsay, do you know who that old man was?" And I had no clue who he was. And it turns out the old man who disagreed with some of my research was Newhouse, the designer of the RAND health insurance experiment. So I felt kind of dumb after that, but I got to meet him, so that was cool. The exercise today is going to relate to the RAND health insurance experiment. 40 years ago was when the RAND health insurance experiment happened. And so recently they just had this big 40-year anniversary to commemorate the experiment. And the researchers, including Newhouse, all got together to just kind of celebrate it and reminisce. And they made a video to just kind of summarize the results and to think about how they went about this experiment. The entire video is very interesting to watch, and I would encourage you to do it if you have the time, but I'm not going to make you watch the entire thing. There's a brief clip, a couple seconds, that I'm going to have you watch, and then I would like you to answer one question related to that clip. And to give you a little bit of background information so that you'll have some context here. In this last lecture, we talked about how the demand for medical care can have different slopes across different goods. So in other words, in some markets where you really need the product, the slope is going to be very steep and it's going to kind of approach a vertical line, whereas in other markets where you don't really need that particular healthcare good, the slope might be a lot flatter. So that's true across markets. What is also sometimes true is that within a particular market, some consumer types have steeper demand curves than other consumer types. And so for this exercise, I want you to think about the market for pediatric emergency room use. So this is the market for ER visits for kids. And within this market, there's different types of kids who might go to the ER. And so what I would like you to do is to think about two types of kids. Think about sick, poor children, and then children who are not sick and poor. And the tasks for you after you listen to this clip is to respond which group of children you would expect to have a steeper demand curve for pediatric emergency room use, where the options are poor sick children or children who are not sick and poor. Which of those two groups do you expect to have a steeper demand curve for pediatric emergency room use? Once you submit your response, you'll be done for the day. Just make sure it's turned in before the end of class time, and I will see you next class.
Cost sharing reduced unnecessary medical care, but it also reduced necessary medical care. And I remember the study of pediatric emergency room use. And cost sharing reduced that, particularly for poor, sick children. I thought that deserved more attention.